everyone. I hope you can hear me, and thank you, Erica, for the great introduction. My name is Jean Davison. I am a clinical associate professor at UNC-Chapel Hill, and I'm also a family nurse practitioner. So I'm delighted to be here, and we appreciate this opportunity to present. We wanted to do it as a panel because it's really been a team effort of the telehealth that we have done over agricultural season in 2020. So that's what we want to share with you. I want to begin by taking us back to March of last year. If you can all recall, I know COVID to me seems like we've been in this pandemic for years, but obviously we just hit a major milestone, and it has been a year since March 13th, 2020, when our President Trump declared the coronavirus a pandemic and a national emergency. This declaration really allowed the CMS and every hospital to go into emergency preparedness plan. It was very daunting at first because of patients' schedules being uprooted, not being able to come into clinic. I know for us, as far as at the university level, we had a lot of students in clinical sites that had to be pulled out because of the lack of masks and goggles and gloves that were really reserved, especially for the ICUs in our hospitals. But in addition to all of that going on, the emergency declaration did allow for some innovation, especially when it came to telehealth. And that's really what we want to talk about today. In our state of North Carolina, we had a very proactive governor that also declared it an emergency and started implementing a shelter in place that began actually on March 30th, 2020. And again, the reason to shelter in place was to decrease the spread of the COVID-19. But at that time, that was actually when our farm workers were coming into North Carolina. And they were considered essential workers, and so they were not able to shelter in place as the rest of our state. So a little bit of background as to why farm workers are really at risk for COVID-19, and I'm sure that none of this surprises any of you. Farm workers, again, are considered essential workers. And so when everybody else was sheltering in place and able to keep distant from each other, farm workers were not necessarily able to do that, especially those that lived in migrant housing. They often share toilets, they share showers. When the distance is supposed to be 50 square feet apart, a bed by itself can be 7 foot long. And so actually having that 6 foot of distance between beds is almost impossible. In addition, when they're on buses and they're being transported out to the fields, they're oftentimes sitting right next to each other. And even a lot of the H-2A workers, when they were coming up from Mexico, we had some situations in which somebody on the bus had active COVID and spread it to others on the bus, in which they went out to multiple farms, which started outbreaks on some of the farms. We also know that because of the historical low wages for migrant farm workers and no benefits as far as unemployment benefits or sick leave or health insurance, they have definitely been at a disadvantage to not only seek health care, but also to be able to take time off work when they're not feeling well. And most of them actually did not want to go into isolation or be quarantined because they did not want to lose wages. The group that I have worked with under the North Carolina Farmworkers Health program is the North Carolina Farmworkers Project. That is a 5013C organization. It serves approximately 3,000 migrant and seasonal farm workers in 5 counties around Benson, North Carolina. And that's pretty much, for those of you that don't know the geographical area, that's pretty much central North Carolina. They have been in the community for over 20 years. And so the outreach workers have really built very trusting relationships. And we could not have done any of the telehealth that we did without our outreach worker, Vicki, that has really helped not only find who needed to be seen by telehealth, but also did a lot of the follow-up. So we all have worked together, both as in terms of our medical director, Dr. Gail Thomas, myself, a nurse practitioner. We also had a PA who was helping us with telehealth. And our nurses from UNC that are in our Doctorate of Nursing program helped in delivering this telehealth. So our objectives for this time are to discuss why farmers are at risk, how to decrease the risk of infection, strategize how to set up telehealth for the farm workers, how to screen for it, how to decrease the barriers to testing, and education for prevention. And then at the very end, we'll have time for questions and answers that you may all have. So I'd like to begin really talking about that first objective, which is discussing why farm workers are at risk for contacting COVID-19 and how to decrease the risk. I know I'm preaching to the choir, as they say, in that all of you know the very many reasons why farm workers are at risk. And I wanted to share with you some of the health disparities that we have seen in North Carolina, and to really remind everybody that in some of our counties, it's almost been the leading cause of death. So we have a really nice COVID-19 dashboard, which I'm hoping that you all can see right now. And it basically tracks the number of cases that we have on a daily basis. And we had a very high amount of new cases in January, and it's starting to come down. It also tracks the completed tests, how many are hospitalized. And at the height, we've had about 1,500 in North Carolina hospitalized at one time. But it also shows a geographical map. And I really want to kind of point out where the North Carolina Farmworkers Project is. It really covers pretty much Johnston County, Wayne County, some of Sampson County. Den is actually pretty much in mostly Sampson County. And you can see on the map, it talks about the percentage of the population that are considered high risk. And Sampson County is one of the highest risks right now in North Carolina, where the project is at. Duplin County has been known throughout the nation for being one of the highest per 100,000 residents of actually not only having COVID-19, but having some of the highest deaths. So that's kind of where we're at. I'm not going to go back and forth between the PowerPoint, but while I'm up here, I was just going to point out some of the other things I'll be referring to, which is the CDC does have a nice website set up for agricultural workers and employees. This is the North Carolina Farmworkers Health Program, in which we have been very proactive in the guidelines around COVID-19. Another resource that I highly recommend, especially if you're trying to set up telehealth and use evidence-based guidelines, is the Migrant Clinicians Network, which is really helpful in all of that. And lastly, the CDC also has the COVID-19 tracker. So I'm going to go back to the PowerPoint, but I just wanted to point out some of those sites, and if you want further information, especially about nationwide in the state when it comes to COVID-19. So I must admit, I gathered a lot of this information about why migrant seasonal farm workers are at risk from the Migrant Clinicians Network. It's one of my favorite resources. And right from the beginning, we knew that these essential workers would be at risk. Again, going over what we've talked about, which is the lack of health insurance, the lack of access to health care, concerns around lost work and lost wages, the lack of unemployment compensation, the unsanitary crowded housing, and also H-2A workers were really having a lot of problems with visa processing and transportation from one site to another, along with coming in. So again, the Migrant Clinicians Network is a wonderful resource for all of us that work with migrant seasonal health workers. One thing that people sometimes lack understanding in is what we call age-adjusted deaths. So because the Latinx population does tend to be younger, we always think that the burden of COVID deaths is predominantly in the white community because of the fact of a lot of people from nursing homes and older age, such as in their 60s, 70s, 80s, have been dying disproportionately from COVID-19. And that's true. But when you adjust for age and you realize that the Latino population is much younger, you will see that Pacific Islanders and Latino and Indigenous and Blacks are dying at a much higher rate of COVID-19 than whites and Asians. So again, going back to March of last year, which was the beginning of our agricultural season, normally on Tuesday evenings, we go out to farms. And in the farms, we take our mobile health van and we see patients. We knew we could not do that last March, again, because of lack of PPE, outreach workers, sheltering in place. And so we decided to transform the health that we were providing by using telehealth. So there are certain requirements, especially in North Carolina, that have to be met for somebody such as myself, a nurse practitioner, to deliver telehealth. First of all, I have to be licensed in North Carolina, and the patients that I see and write prescriptions for also must be in North Carolina itself, because that's I'm under the Board of Nursing for that. Also, when we start out delivering the telehealth, we have to verify that the person that we're talking to is the correct person. And so we must verify their identity. We also must use and ensure encryption. We did use WhatsApp, which does have encryption with it. It's not your typical telehealth application that you might use in a hospital or other setting. But for the purposes, especially during COVID-19 and the federal waiver that we had in place, we were able to use it. And it's a resource that's really great for farm workers because most of them on their cell phone have WhatsApp so that they can communicate with others, especially in different countries. The other thing that's really important part of telehealth is making sure that you have the patient's location and the patient's telephone number. And so our outreach worker was very good about making sure that she had the patient's contact telephone number. She began the call on WhatsApp and then would bring us into the call once it was established. Also, she knew the location, the farm that the patient was at. Because if you ever have a situation where you have to call EMS or you get somehow cut off, disconnected when you're on a phone call and you're concerned about the patient, you need to know how to call back the patient and also how to send an ambulance if you need to that location. So that's very important. We also needed to identify who was on the phone call, the video call that we did. And so we would always start out introducing ourselves and who we were. We would, again, verify the patient. We would ask for verbal consent to establish the telehealth call. And again, we would make sure that the patient knew who they were talking to, and we knew who was in the room with the patient too, because we had to make sure that it was okay for us to have this conversation, which is HIPAA protected. So at this time, I'm going to introduce our famous outreach worker, Vicki, and one of our D&P students who has worked very closely with us in telehealth, and she is a pediatric nurse practitioner. And I will turn it over to them for questions and answers on how you could strategize in setting up telehealth, working with your farm workers.
Hello, everyone. I am Betty Martinez. Like Dr. Davis had said, I'm one of the nurses as part of the telehealth team. And today we have Vicki. So we know her as Vicki, but she's Gabriela Elvil Hernandez, and she is the outreach worker that worked in Central North Carolina with us as part of the telehealth health program. So in order to understand more about the project and how it worked, I'm going to go ahead and do questionnaires to her, and she will respond. I will ask them in English and in Spanish. She will respond in Spanish, but I will summarize her responses in English as well. So, Vicki?
Hola.
Hola. So can you tell us a little about the NC Farmworkers project in Central North Carolina? ¿Puedes contarnos un poco sobre el proyecto de trabajadores agrícolas de Carolina del Norte?
Sí, claro. Buenas tardes a todos y gracias por estar en esta sección. El proyecto de trabajadores agrícolas en Carolina del Norte es una organización sin fines de lucro que comenzó en el año de 1994 como un proyecto comunitario para responder las necesidades de la comunidad de trabajadores agrícolas. El proyecto de trabajadores agrícolas se mudó a Benson, Carolina del Norte, en el año 2000.
Okay, let me translate that, Vicki. The North Carolina Farm Worker Project is a nonprofit organization that began in 1994 as a community health project to serve the needs of the farm worker community. The Farm Worker Project moved to Benson in 2000.
Okay. Iniciamos nuestro programa de salud con fondos de la Oficina de Salud Rural en el 2004. El programa de salud ha crecido constantemente hasta convertirse en nuestra mayor área de enfoque. Les brindamos educación para la salud sobre diversos temas, visitando cada año 3,000 trabajadores y familias. Nuestra misión es promover la organización de los trabajadores agrícolas para que encuentren soluciones a sus problemas de manera colectiva. Fomentar la participación política de los trabajadores agrícolas y mejorar sus condiciones de vida y trabajo.
Okay, thank you, Vicky. Let me translate that.
Sí.
The health program started with funding from the Rural Health Office in 2004. The health program has steadily grown to become the largest area of focus. They provide farm workers with health education on various topics, visiting 3,000 workers and families every year. The mission is to promote the organization of agricultural workers so that they collectively find solutions to their problems, encourage the political participation of agricultural workers, and improve their living and working conditions.
Ok. Hoy en día el Farmworkers Project tiene 10 empleados durante todo el año, muchos más pasantes de verano y personal a tiempo parcial durante la temporada alta. Y también contamos con colaboraciones con Wake Forest University, Campbell University, UNC y Benson Health, y muchas otras organizaciones de trabajadores agrícolas en todo el estado.
Thank you, Vicky. Today, the Farmworkers Project has 10 year-round employees, many more summer interns and part-time staff during the peak season. But we also have partnerships with Wake Forest University, Campbell University, UNC, Benson Health, and many other farm worker organizations across the state. Thank you, Vicky. Now our next question. Can you tell how the process in identifying who needed healthcare services and explain it to us? ¿Puede decirnos cómo el proceso de identificar de quiénes necesitaban servicios de atención médica?
Claro. Por lo de la pandemia se innovó este tipo de clínicas por videollamada. No podíamos visitarlos cara a cara como otros años. Se nos hacía muy difícil para todos no poder ayudarlos. Entonces cambió toda la manera de cómo trabajábamos. Todo lo hicimos por llamadas telefónicas a familias y trabajadores. Ahí vemos las necesidades que tenía y ofrecemos los servicios de la clínica. Entre ellos se pasaban la voz a los demás sobre las citas y ahí identificábamos las necesidades y ofrecíamos nuestros servicios de telesalud. Cuando ya empezamos las visitas a los campos a mediados del año, ahí se informaba sobre las clínicas de telesalud, identificábamos cómo un paciente tenía un problema crónico o otros problemas de salud. Enviábamos mensajes de texto, mensajes por WhatsApp para decirles que teníamos servicios de clínica, de televideo. También hacíamos flyers promocionales sobre las citas de Telehealth.
Thank you, Vicky. Let me just translate that. Due to the pandemic, this type of video call clinic was innovated. We could not visit them face-to-face like other years. It was very difficult for all of us to be able to help them. Then the whole way it worked changed. All were made by phone calls to families and workers there. We saw the needs they had and we offered the services of the clinic. Between them, they passed word of mouth to others about the appointments. And they were identified also by their needs and offered telehealth services at the camps itself. When we started the visits to the fields in the middle of the year, they were informed about the telehealth clinics. And we identified when a patient had a chronic problem or other healthcare issue. She also states, I sent a text message or a WhatsApp to tell them that they had an appointment by televideo that day. And they also did promotional flyers about telehealth appointments throughout the campuses. They were posted. Mm-hmm. Now on our end, as one of the nurses as part of the team and providers, Vicky would send us the information the day of the patient's information and what their concern was so that we were able to prepare for that evening's visits and see how many patients we had. Mm-hmm. So Vicky, to the next question.
Okay.
Please explain the process, how you connected the patient to the provider. Explique el proceso de cómo conectó el paciente con el proveedor.
Ok, usábamos la plataforma de WhatsApp. Primeramente llamaba al paciente por la videollamada, luego agregaba al proveedor de salud, luego agregaba a la enfermera y hacíamos una conferencia de 4 personas el paciente, el proveedor de salud, la enfermera y el average worker.
Okay, so let me translate that.
Mhm.
So she would conduct the telehealth calls through the WhatsApp application on the phone. The patient was contacted on the video call. The healthcare provider was added to the call, and then the nurse was added to the call, resulting in a conference call between the patient, the healthcare provider, the nurse, and the outreach worker.
Okay.
So on our end, as the nurse is getting the information, and we were also make sure, like Dr. Davison said, to confirm the identity before we even started by date of birth and their names. And then we would ask for consent, obviously letting them know what the visit would entail and that we did have limitations because everything was done by video. And if we needed to seek other healthcare, then we would let them know. Obviously, it was no cost to them. We would do a depression screening, we do a COVID screening, and then we would ask the questions pertinent to their concerns. And I believe Leonora and Sophie, our other nurses, will provide more detail about that. So to our last question, Vicky, and how did you arrange the services, equipment, and medicines needed after the telehealth visit? ¿Y cómo organizó los servicios, equipos y medicamentos necesarios después de la visita de telesalud?
Ok, el proveedor de salud utiliza unas formas con la información de los pacientes que es Telenow y los Medical Encounter Form. Esas formas del proveedor de salud documenta toda la información sobre el paciente. Si tiene referidos, si le recetó medicinas, si lo va a referir a una prueba de COVID, si quiere que le checar la glucosa o la presión.
Okay, let me translate that. So the healthcare provider uses a preset form with the information, the patient demographics and the required information of the patient. The North Carolina Farmworker Health Program Telehealth Note is what it was called. There's also another note, the 2020 North Carolina Farmworker Health Program ICD-10 Medical Encounter Form, and this is where the codes were documented. In these forms, the healthcare provider would document all the information about the patient and what was needed. If there were referrals, if they needed medicine, if they needed COVID testing or lab testing, fasting blood sugars or blood pressure readings or checks, or even medical equipment or supplies, etc. So continue, Vicky, go ahead.
Okay. Thank you. Luego el proveedor me envía por email toda la información del paciente de la visita que tuvo el día anterior. Le decimos formas médicas de los pacientes. Yo imprimo las formas, reviso paciente por paciente, veo qué medicina recetó el doctor o si tiene algún referido. Si recetó una medicina, voy a la farmacia, recojo la medicina del paciente, luego se la hago llegar en el campo en donde ellos viven. Si son medicinas recetadas, el paciente paga su medicina. Si son medicinas genéricas, nosotros le proveemos la medicina gratis. Si tiene un referido, llamo a la clínica para hacer la cita. E igual, si tiene prueba de COVID, también hago el mismo proceso.
Okay, let me translate. Then the provider sends the outreach worker the patient's medical forms by email. She prints them and reviews patient by patient to see what medicines the doctor prescribed or if any referrals were needed or any other services. If medicines were, I'm sorry? Oh, I thought I heard something. If medicines are prescribed, the outreach worker, or like Vicky, goes to the pharmacy and she picks them up and then sends them to the patient the day after the appointment. Prescriptions are paid by the patient, but if they are generic drugs, it is provided for free. If there is a referral, their outreach worker will call the clinic to make that appointment for them. And if there's a need for a COVID testing, it goes through the same process. So she makes the phone calls. So as providers on the other end and nurses, we made sure to write those and document exactly what the patient would need, and try obviously to look, depending on the location of the patient, prescribe to the right pharmacy, and obviously prescribe the medication. If we can do generic, that would be the best thing to choose. We would also verbalize it to Vicky, because she was on the phone call, to confirm the orders that the provider had put on the document. And this was to ensure that they got the right medication for the right supplies. And again, believe Leonora and Sophia will talk more about this. But Vicky was instrumental to this process as an outreach worker. We definitely couldn't do our end. She was the bridge that brought it all together for this telehealth to be successful. So she's a very, very important team member. Thank you, Vicky. Thank you very much.
Thank you, Vicki, and thank you, Betty. Good summary of what our telehealth looked like and how we were able to put it together. So now we're going to talk about a little bit more in depth on how we screened for COVID-19 symptoms and decreased barriers to testing, along with the education. And a lot of this was done through both the interviews, and part of our plan was for every patient that was seen was both screened and provided information to prevent COVID-19.
Hello, everyone. My name is Leonora Tisdale. I am a family nurse practitioner student, and I've really enjoyed working with the other folks on this panel. And we also appreciate you being here to let us share some information with you. So this slide highlights sort of what Dr. Davison said early. We saw it coming. We knew that migrant farm workers were going to be more affected by COVID, and they were. That is what this data shows, that the Latinx community is about 10% of the population of North Carolina, but accounted for almost 40% of the confirmed COVID cases. And it's very possible that that percentage is lower than actuality. You can see above, Yeah, go on to Sophie. That's great.
Good afternoon. So my name is Sophie Draffin, and I am currently working as an RN at our COVID ICU here in the area. And I'm also a family nurse practitioner student at UNC. And over the last year, as we know, screening for COVID symptoms has become a regular routine for many of us before dental or medical appointments, before going to work or to school. And the screening has become an integral part of our lives. Likewise, it was essential to screen these farm workers who, as Leonora said, are disproportionately being impacted by COVID-19 and who do not have the same access to medical providers and resources regarding the symptoms and precautions. This is why it was important that we screen each and every patient who called for an appointment, whether they called for a rash, cough, nausea and vomiting, or an eye infection. It was important to review possible COVID-19 symptoms. We did this simply by asking about symptoms and asking if they had any sick contacts. And over the summer and fall, as our medical community learned more about COVID-19, we learned more about the various symptoms. And I know that these are all very familiar to us, and we've heard them many times, but the symptoms of fever or chills, cough, shortness of breath or difficulty breathing, fatigue, muscle or body aches, headache, a loss of taste or smell, sore throat, the congestion or runny nose, nausea or vomiting or diarrhea. And in the presence of any of these symptoms, there is a very low suspicion to refer a patient for a COVID test. And now I'll turn it back to Leonora to talk about who should be tested.
So in addition to the folks who presented with with the COVID symptoms, there's also recommendations for others to get tested in North Carolina, even if they don't have symptoms. And these groups include folks in congregate living areas, historically marginalized populations, and frontline essential workers. And of course, our migrant farm workers fall into each of those categories. Interestingly, I want to say, or perhaps not surprisingly though, what we experienced was power dynamics and socioeconomic factors that really impeded people from being able to be tested. One of those, for instance, an example from our experience was a person presented with pretty classic COVID symptoms, cold, but it was pretty clear he needed to be tested. we recommended testing. Vicky was able to set up an appointment on his behalf at the local health clinic, but the patient had no transportation. Rural North Carolina it's not uncommon to have to drive quite a distance to a health clinic. By law, the owner of the farm should have provided transportation for the patient to the clinic. But if you think about the power dynamic of a migrant farm worker who probably doesn't speak English very well, approaching a boss to say, I might have a disease that we're seeing people die from on television. Would you please drive me in your pickup truck to the local health department or clinic to be tested? And then if I do have that, or I don't, even if I get tested, I won't be able to work for the next 2 weeks. I mean, pretty quickly, people would be like, I feel okay. I don't think there's anything wrong with me. So we just really saw a lot of overlapping of socioeconomic factors, larger societal power dynamics at play, and really impeding people's access to testing and care.
So at the end of every visit, after referring people for tests if needed, we always discuss COVID precautions as well. And this involved, I know you've all seen the 3 Ws: to wear a mask or face covering, wait at least 6 feet apart, and wash your hands with soap and water, or use hand sanitizer frequently. And it's easy for me to sit here and talk about the 3 Ws. And for many people, these can be followed without too much disruption. For many of the patients we talked with, however, it was not easy to follow the 3 Ws. For example, as Dr. Davison mentioned earlier, it was difficult for some patients to self-isolate if they're experiencing COVID symptoms because they shared tight living quarters with several other farm workers. For some, there was limited access to face coverings and cleaning supplies. But in the face of these challenges, it was important to chat with these patients and brainstorm with them about what precautions they could take, how to protect themselves the best they could, what resources did they have, what else would they need. And we were very thankful for our community partners who were able to help provide some of these needed supplies. And now we'll turn it back to Dr. Davison to continue with the last part of the presentation.
Thank you. As you can probably hear, there's passion in this panel. And again, it was a team effort, and everybody did an amazing job in doing what we could. So a little bit about our outcomes. Question is always, how many patients can you see on telehealth? On average, we could see about 2 patients an hour because of having to make the calls, having to get everybody on the line and go through the consents, et cetera. And so we actually started telehealth in April, and we continued all the way through November when the migrant workers were moving on to other things within our state, such as the Christmas tree farms. More than 50% of the patients that we saw did verbalize that they had COVID-19 symptoms. And of course, there were many outbreaks on farms throughout the whole agricultural season. As others have shared, trying to find even places for the farm workers to quarantine or isolate was very difficult. And even when testing became hard to go to testing center, we actually, towards the end, were able to partner with a mobile clinic that went out to do the testing at the farm. But even with that, many farm workers were reluctant to go forward and be tested because they didn't want to miss work. They didn't want to be isolated. They didn't want to lose those wages. And the growers oftentimes did not even want the health department coming on to investigate a farm worker outbreak. So we can share stories. Some of the stories, though, do have good endings in the sense of when we were interviewing one couple who were very symptomatic with COVID symptoms. The female, she was so short of breath that when we would ask questions, she would have to stop and catch her breath or started coughing a lot. And she was also experiencing fever. And her male partner was right next to her. So they were both really not only symptomatic, but one was severely symptomatic. We were able to encourage her to go directly to the ER, and she did get admitted for severe COVID, and she stayed in the hospital, was treated, and was a good result of being discharged and has recovered. We have other stories like that too, but there were a lot of frustrations, and there are still frustrations because even with the guidelines in place, oftentimes the policies do not support enforcement of both testing and screening and offering days off, paid days off. So we did feel, though, that telehealth is a great innovation, especially with working with the outreach workers. And the reason is because the outreach workers can go out to the farms and be there much more than we can be there. And so we do plan to continue telehealth services even throughout this agricultural season. In addition, we hope to start going out on the mobile van again and seeing patients face-to-face, especially for those that need the hands-on exams. But telehealth has really proven to be very successful in being able to get prescription refills for those with blood pressure and diabetes, also to be able to screen and kind of triage patients to see whether or not they're stable enough to wait and be seen in the clinic this week, or whether they need to go to the ER that night. So going forward, as I said, we do plan to continue the telehealth, but we also really want to be proactive right from the beginning of the agricultural season. The recommendations are to screen and test upon arrival before going into congregate housing, such as the migrant housing. Also, to provide information on the 3 W's and give free masks and hand sanitizer. This picture happens to be Betty and Leonora, who are putting together what we call welcome packets, which include the mask, information about COVID, hand sanitizer, and other items that the farm workers receive right when they come into our state. And if you've been listening to some of the conferences, it sounds like for H2A workers are offering actually screening to be done in some locations such as Mexico before they get on the bus, and then, transmit the COVID to others that are on the bus going out to all the different farms. We also feel that growers and farm workers organizations should promote vaccination and make it culturally and easily accessible. There is no policy in place that they have to do that. It's a recommendation, and we would love to see policy in place that they have to at least offer it. Paid time off, of course, isolation housing continues to be an issue. And those are, again, policy issues that really go all the way up to the federal level as far as workman's comp and paid time off for agricultural workers that are often excluded from those sort of benefits and rights. So we feel, in addition to guidelines, that policies should be in place and enforcement should be in place in order to protect the farm workers, in order to protect the community, and to get our economy really back going again. It's a win-win situation for everybody. So at this time, we wanted to open it up to questions and answers. Hopefully we can provide some answers. So we'll look at the chat box. In addition, I have included some resources. I think you've already heard about the CDC guidelines for agricultural workers, which is a wonderful kind of toolkit to put together. The Migrant Clinicians Network, again, has been wonderful for me as a provider to have these sort of resources available. Our North Carolina Farmworkers Health Program not only has great information, but it also has some of the forms and the handouts that we have used both in our health screening when farm workers first come in, and also the resources that we are able to provide. I also referred to an article called Telehealth Transformation, COVID-19 and the Rise of Virtual Care. It does give you some general information about starting up telehealth, and it's been a real learning situation for all of us, but I think we've all grown and have been innovative with it, and I do believe that it really can transform healthcare and make it a true teamwork situation between the outreach workers, the farm workers, and the healthcare providers. So at this time, I'll open it up to questions, and let's see if we have any in the chat box.
We do. We have just one question for you all, and that is, well, actually two, and one of them we've already been able to answer. We were able to put the links to the resources you shared at the bottom in the chat, but we do have a question around, did you state that you all have an executive order of all ag workers required to get COVID tested?
I wish we did. I actually have a student that is working on policies. It's not policy in the sense of being enforceable. It's wonderful guidelines. Those that work with the North Carolina Farmworkers Health Program have had guidelines out from the beginning. But unfortunately, it is not enforceable. But our suggestion is that it does become legislatively enforceable in North Carolina to at least offer the testing, the screening for free, and the vaccine for free. And in North Carolina, we're pretty much at that point now where we are offering vaccines to all essential workers based on groups that they're in. And we do have right now, we have at Benson Area Medical Center, we have a vaccine date in which the medical students and some of us who are volunteering will be out vaccinating the farm workers as they come in early April. And our goal is to get everybody vaccinated.
Awesome. And we've got quite a few questions that are streaming in. We've got just under 10 minutes or to get through these. So I do want to try to be mindful of the questions that are coming in. But we do have one question from someone that sounds like they are a brand new provider in the field. And their question is, how do you ask for consent to do telehealth visits in a culturally meaningful sense, and that they don't bill currently for insurance, and to our patients just to see a call as a friendly conversation with a helpful advocate? So consent to their patients is met with blank stares. So do you bill insurance, and does that change the consent questions? And there's a couple more in here as well.
We do not. Our services that we provide are free through the mobile health clinic, whether we're out in person and also with telehealth. It does, the funding for it falls under, I believe, the Office of Rural Health is how we're partially funded for the program, but the farm workers themselves do not get billed. There are, I will let Vicki answer in terms of like medication costs, because I know we work with a pharmacy in a 403B program. And then I'll also let Betty and them talk about how we did consent in a culturally sensitive way. So I'll let them respond to that. Vicki, do you want to respond as far as costs for medications or diabetes supplies, things like that?
Ok. El programa de salud, tenemos un programa de 340B, que cada trabajador se le da una tarjetita, entonces ellos pagan una cantidad mínima sobre su medicina, ya sea $4 o $10, depende de la medicina que le receta el doctor.
So there's a special program that they offer the farm workers. They give them a card that they have like a minimal payment on it, sometimes $4 to $10. And this gives them benefits for medications to cost a lot less.
Mm-hmm.
I was just going to address part of the other question I saw in there about losing a lot of nonverbal information and body language and facial expressions. And we definitely struggled with that. It was helpful to have the video feed, but as you can imagine, internet is spotty in rural North Carolina. So people's video feed would cut in and out. We would see like a lot of people's chins. If people had like a rash or, I mean, some people called like needed a prescription, had like a athlete's foot or like jock itch. And, you know, you don't want to be like, can I see it? So finding ways to describe it, or some people would feel comfortable like taking a picture, like we would get off the phone, go take a picture, send it to us, and then come back on to talk with us. So we kind of found it's definitely imperfect, but we kind of, you get creative.
Awesome. And the next two questions sounds like they're somewhat related, but one asked about what kind of media communications work for you the best. And there was a mention of WhatsApp. And then the second question that somewhat ties in, it says, do you ever encounter a person who does not know how to use WhatsApp or a telephone, and how do you help those individuals?
It seemed like WhatsApp was the most user-friendly, and it seemed like everybody had that on a cell phone. And if they didn't have a cell phone, it seemed like one of their buddies had a cell phone. And again, with many of our farm workers coming from Mexico and other places, WhatsApp is a very popular to use, and it is very protected as far as encryption. And as Leonora said, at least we could visually see their expressions and see if they were in any acute distress as kind of a general survey when seeing a person. And also we would ask them to zoom in on things as we were taking a history and they had a specific area that they were concerned about. So there was some visual things, but of course you can't do any hands-on. But anybody that we felt we needed more information, that actually needed a physical exam done, we would get them an appointment with the clinic that we worked with. So again, a big part of what we did was screening and triaging. And triaging to say this person is in no acute distress, they're stable enough that I can either call in their refills on their blood pressure medicine until they're able to get into the clinic, or this is somebody I need to send to the ER like right now, which we have had one or two like that we had to do that. And then I was going to let Sophie or Betty talk about how you asked for consent in a culturally competent way.
So when we asked for consent, we basically just introduced what we were doing, the fact that we were using their WhatsApp application, which is a communication device that's free. And I think that's why it's so popular among the community, Latin community. I have family in Spain, and that's what they use. They use a WhatsApp application because it's free of charge. We basically told them that we were using this application. We told them the limitations, that they were not going to get charged, but that there were limits to what we can do because that we were not there physically. And if they understood that and they said yes, and were you okay with that? And yes. And again, we would tell them sometimes we'll offer you the opportunity to go to the clinic. And I know there was a clinic, a at some point that they could go to once a week, or that would be in the area that they can get to. And Vicki, again, would coordinate all those services. So we were just open and upfront, and I don't remember ever having a patient saying, no, I'm not okay with that. Everybody was very open, and communication sometimes, like Leonora said, we had to get creative. There were some calls that we just had to do over the phone because their video was just so bad. And again, we saw these patients after work. So they were literally getting right off work, right before they had dinner, right before they, go to their homes. So where they were at, sometimes the connection was not the best, but we adjusted. And I think it was a continuous quality improvement that we did every time we had visits. But we made sure that we gave them the information as clear as possible. Sophie, if you want to add anything about the consent.
No, I mean, I think you hit all the main points, just sort of summarizing that there was no charge, and making sure that they were comfortable with everyone that was on the call and introducing ourselves, and then going into what the visit would entail.
There was also one of the things that we did was anybody with a history of diabetes, high blood pressure, things like that, that needed medication refills. And we knew that it was hard to get clinical appointments no matter where they lived because of COVID. I would ask the outreach workers to take a blood pressure monitor out to them, or blood glucose monitor out to them, and get the results of the screening. And most of the time we were able to supply glucometers with strips and blood pressure machines for them to use to monitor their blood pressure. And then I would write at least a month's worth of the medication, so they would have time to get an appointment and get into clinic to get additional lab tests that obviously we couldn't do.
Okay. And I think we have time for just one more question. There's a couple that are in the chat. So if any of you folks on the panel want to type those answers in, I think we all might already know the answer to this, but in regards to interpreters available for folks that don't speak English as their native tongue. And then what's the percentage of your migrant population that are H-2A workers? I think that was on the slide. And then there was one other question that was just above that one, I think. What kind of telehealth equipment are you all currently using, and are you using this at your migrant camps? That's the one.
So we're still using WhatsApp right now, because that has worked best for everybody. We also have worked with mental health services, and they use Zoom. So Zoom is an option too. And at least at UNC, we are able to have security around Zoom, the type of Zoom that we use. So that's also an option too. But WhatsApp seemed to be the best for farm workers as far as their comfort level. And the question about percent of H-2A workers, I'll let Vicki answer that one.
Sí. ¿Me puede repetir la pregunta, por favor? Can you repeat the question?
So the question was, what is the percentage of your migrant population that are H-2A workers? And someone's thank you for answering in the chat. Awesome. And then, okay, I said that was the last question, but this is the absolute last question. And thank you, panelists and attendees, for holding on. But Grant has another part to his. If you all can talk a little bit more about the role of the nurse and the outreach worker on your calls. Were they doing the translation? Were they summarizing the initial intake? And how helpful was this in making the telehealth visit feel like an in-person visit?
The three students that I work with, Leonora and Sophie and Betty, all speak Spanish, and they're registered nurses that are working on their doctorate of nursing practice as family nurse practitioners. So they have been trained to do the histories, the assessment, the diagnosis, and the plan. And so basically my role as faculty and as the lead provider was to monitor and make sure they were asking the right questions. We were getting everything that that we needed, and any prescriptions and things like that that needed to be done. I did, because that was my role, and I'm the one with the license. And in terms of, we made it as humanly friendly as possible, trying to make it at a time that was appropriate for the farm workers to be able to get on, to do it in their language. And so I think for the farm workers, it was very easy to call in, to be called on WhatsApp. And again, the outreach worker, Vicki, really set it all up, and she has this relationship with them, and she is the one too to make sure that our plan was carried out afterwards. So the communication, I think, was 360. I really think that the handoffs and everything that we did, the only time the handoffs did occur oftentimes was either the growers did it, the person to take time off to go to the clinic, or transportation became an issue. But as far as everything possibly that we could do was done.
Awesome. Well, folks, I hate to end this session, but we do have a virtual exhibit session in between this that we'd love for you all to attend. Thank you to our panelists. Awesome job. Thank you to our support system helping on the back end with this, and attendees. Most importantly, thank you for joining. We ask that you please complete the survey link that was put in the chat earlier, so we'll be able to provide feedback to our presenters. If you can, make sure to fill that out, and then we'll see you in the next session. So thanks for joining us. Bye.
Thank you. Thank you very much. We love being here.